Hey everyone, welcome back to Static Cardiology here on EMTV. I'll be giving you an ECG rhythm and a scenario. On the bottom of the screen you'll see a timer for 1 minute and 30 seconds. This time closely resembles the average amount of time you'll want to be spending on each card during an actual National Registry exam. When the time is up, we'll go over the rhythm and I'll give you my treatment. Enjoy the card and good luck.
3, 2, 1.
Now before we jump into this, I want to give a quick shout out to Lane Community College in Eugene, Oregon, and Central New Mexico Community College in Albuquerque. Thank you for your continued support of the channel. Now let's go ahead and take a look at this rhythm in a little bit closer detail. Now right off the bat, you're seeing a couple variants of a QRS complex. Let's examine the smaller ones first. Now these smaller QRS complexes have a P wave and narrow QRS and an associated T wave. Now despite what this looks like, this wave is actually not a P wave for the following complex. This is a T wave of the complex that precedes it. Knowing that, this following complex is a wide QRS and no P wave, meaning it can only come from one spot within the heart, the ventricles. Now if you remember from the scenario that this patient's palpable pulse was only 40, I'm going to consider all of these to be PVCs. Back to my normal beats, the PR interval here is within normal limits, the QRS complex is nice and narrow, and the rhythm appears regular. So my rhythm here I'm going to diagnose as a sinus rhythm with bigeminal PVCs. You could further expand this diagnosis by adding that these bigeminal PVCs are unifocal in origin, meaning they're identical to each other. Let's go over the scenario next. You are dispatched to a private residence for a 70-year-old female complaining of shortness of breath. Upon arrival, you find your patient sitting on the floor near the stairs. She is alert and reports that she became out of breath while climbing the stairs and had to sit down. She became concerned that her shortness of breath became worse despite resting, so she called 911. She denies trauma and reports a history of high blood pressure and high cholesterol. Physical exam reveals cool, pale skin, clear lung sounds, and a weak radial pulse. Your partner obtains the following vital signs: blood pressure 81/33, pulse 40, respiratory rate 36, SpO2 88% on room air, and a blood glucose reading of 144. You attach the monitor and see the rhythm above. Now, one of the most important aspects of static cardiology in order to be successful is to determine whether or not this patient is stable or unstable, so you can choose the appropriate algorithm for treatment. For unstable criteria, I use the acronym CHAD. And this, of course, stands for cardiac insufficiency, hypotension, alteration in mental status, and dyspnea. Now, based on my patient's presentation as well as her vital signs, she's hypotensive with a blood pressure of 81, and hypoxic and dyspneic with an SpO2 of 88% on room air. My final diagnosis for static cardiology is an unstable sinus rhythm with bigeminal PVCs. Now, let's go ahead and move on to the treatment. I'll begin treatment, just like I do with all my other cards, by regurgitating the mantra. Scene safe, BSI, IV O2 monitor. Because this patient is bradycardic, I'll then consider administration of atropine, 1 mg IV push, given every 5 minutes, up to a maximum dose of 3 mg. Now just be aware with atropine, you have to deliver this rapid IV push, otherwise if it's administered too slowly, you'll cause the patient to become bradycardic. However, because this patient is unstable, and unstable gets the cable, the most definitive treatment here is going to be pacing. So for that, because my patient is conscious, I'll consider sedation. And you can accomplish this with a variety of different medications. For my pacer, I'll attach the pads, turn on the pacer function, and then set a rate, anywhere between 60 and 100 pulses per minute, or ppm. I'll then increase my milliamperage until I see electrical capture. And if you've never seen pacing before, what'll happen is when you turn on the pacer and begin applying electrical current, pacer spikes will appear above the rhythm. You'll achieve electrical capture when you see QRS complex that follows pacer spike. What I always tell my students is you're not trying to catch the rhythm, you're trying to create a rhythm. So your goal is to apply enough electrical energy to actually override the heart's pacemaker system and allow you to pace the heart at the rate that you prescribe. Once you see electrical capture, you'll want to check a carotid pulse, confirming mechanical capture. Beyond this, for additional blood pressure support, you can consider administration of a vasopressor, dopamine given at 5 to 20 micrograms per kilogram per minute, or norepinephrine hung at 0.05, 0.15 micrograms per kilogram per minute. You'll then get a 12-lead ECG, and finally, rapid transport. And that's it. If you enjoyed this video, please make sure to head over to my channel for more. And while you're there, check out my other playlists, Static Pharmacology, and make sure you like and subscribe. I also have merch for sale. Head over to my Teespring shop for brand new Shock Advised merchandise. Thank you again for supporting the channel. Until I see you next time, stay safe, keep washing your hands, and have a good rest of your night.